Hello medicals. In this video I'll be going to discuss about the hyperkalemia, management of hyperkalemia. So how do you manage the hyperkalemia? You first look into the potassium level, serum potassium level. If it is more than 6, we'll check the ECG. If ECG changes are present or if ECG changes are absent. If ECG changes are present, you first stabilize the membrane. The membrane. Then you shift the potassium from blood to cell. Okay. If ECG changes are absent, excrete the potassium. Okay. From here you can go here. Next step. Okay. We'll see in detail. First of all, what are the ECG changes we'll able to see in the hyperkalemia. ECG changes in the hyperkalemia. ECG changes in hyperkalemia. First, tall T waves. Next, widening of QRS complex. Next, flattening of or deepening of P waves. Next, increase in PR interval. Okay, these are the ECG changes in the hyperkalemia. You can remember it by a trick. This is in normal ECG. Okay, P, QRS complex and T wave. Okay, first you go like this way. It's showing widening of QRS complex. Go up, it's showing tall T waves. Go back side, it shows the increase in the PR interval. Then go downward again, it's showing deepening of P waves like this. Deepening of P waves, widening of QRS complex, tall T waves, increase in PR interval. Okay. Now, coming to the management of hyperkalemia. First you will see the serum potassium level. More than 6. Look for any ECG changes. If there, if not there. Okay. If ECG changes are there, you first stabilize the membrane. Stabilization of membrane. So you can prevent arrhythmias, fibrillation, any heart-related complications which is associated with hyperkalemia or deranged electrolytes. First, give calcium gluconate. The next step is shift the potassium into the cell. Give insulin plus minus D50 plus inhale salbutamol plus bicarbonate if acidosis is present. Okay. Next step is excrete the potassium. Excretion of potassium using potassium binding resins in mild or anuric patient. Okay. Same ECG changes are not there, you can follow this. Excretion of potassium binding resins. Okay, examples are sodium, zirconium, Next, sodium propyl sulfonate. Okay, or you can use loop diuretics for moderate to severe hyperkalemia. Okay, now how will you manage the refractory hyperkalemia or recurrent hyperkalemia? For recurrent hyperkalemia, you treat the cause and stop the medication which causes hyperkalemia. First, recurrent hyperkalemia. First, you treat the cause which causes hyperkalemia. Next, stop the medication, discontinue the medication. Continue the medication which causes hyperkalemia. For example, NSAIDs. Next, ACE inhibitor, ARBs. Number 3, potassium sparing diuretics. Number 4, NSAIDs, ACE inhibitors, angiotensin receptor blocker, potassium sparing diuretics, trimethoprim and sulfonylurea. Now, management of refractory hyperkalemia. Okay, it is seen in severe AKI, acute kidney injury. Next, end stage renal disease. We can remove excess potassium by hemodialysis. Okay, this is about the management of hyperkalemia. Okay, morning my ma'am told that one interesting complication about the potassium binders. Okay, it causes intestinal necrosis. Okay, interesting. Thank you.